Okay, let's unpack this. We are diving into a deep dive today that deals with um, immense clinical pressure, really high stakes, and a completely different set of rules than what we usually discuss.
We really are.
We are talking about trauma in children.
And we have to start with the stark reality. Trauma is the leading cause of death in children over the age of 1. Full stop.
And when you look at how it happens,
It's blunt trauma. Overwhelmingly, we're talking about accidents, falls, car incidents. These are incredibly high-energy injuries happening to very small bodies.
so for this, we are specifically pulling our critical concepts, those life-saving distinctions, from Chapter 19 of Baily and Love's 28th edition, Trauma in Children.
Right. And we need to be really clear about our mission here.
Absolutely. So for anyone out there, if you're revising or maybe preparing for a critical rotation, or you just want a solid grasp before you pick up the textbook,
Which you absolutely should.
yes, you should. Treat this deep dive as your essential ready reckoner. It's our interpretation, our distillation of the most critical concepts, the ones designed to stick in your head when you need them.
Our mission today is laser-focused. It's all about understanding the physiological differences between managing a severely injured child and an adult.
Because they aren't just minor points, are they?
Not at all. These differences, they directly impact life or death decisions in the trauma bay. It's that simple.
Okay, so what are the pillars we need to master today? What are we building on?
Well, we're going to systematically assess an injured child.
Huh.
We need to really internalize the key differences in, their injury patterns and how their bodies respond.
And we'll walk through the specifics of the primary and secondary surveys.
The fluid and blood product protocols, which are completely different. And then finally, we'll get into recognizing those subtle but devastating injury patterns that are unique to kids.
It's the difference between just treating an injury and truly saving a child's life.
It really is.
Okay.
So let's jump right in. The first few minutes, the primary survey.
The foundation, of course, is the Structured Advanced Trauma Life Support Approach, the CABCDE.
It's the framework we all know.
We start with C, control of catastrophic bleeding, then airway, breathing, circulation, disability, and exposure.
Right. But while the framework is the same, every single one of those steps is fundamentally modified for a pediatric patient.
Okay, let's start with A, airway.
This is where the very first life-saving modification happens, positioning. In an adult, we often use a maneuver that slightly extends the neck.
The head tilt, chin lift.
Exactly. If you do that to a child, especially an infant, that subtle overextension can actually obstruct their airway. It's more floppy, more pliable.
So what's the anchor? What's the key takeaway for positioning?
For infants, it has to be a strictly neutral position, straight on, no tilt. For older children, we aim for what's called the sniffing the morning air position.
Sniffing the morning air.
Yeah, just a slight angle. It creates alignment because the child's head is proportionally so much larger. Their occiput, the back of their head, can actually flex the neck forward when they're lying flat. Correcting that is absolutely non-negotiable.
And as soon as we talk about airway, we have to talk about C-spine control, which brings us to a truly frightening and exclusively pediatric problem.
Yeah.
Spinal cord injury without radiological abnormality.
And this is a devastating concept because your standard protocol, getting an x-ray to check for fractures, it can give you a completely false sense of security.
The picture looks clean, but the damage is done.
Exactly. The mechanism is often cervical hyperextension, maybe from a rear-end collision or a severe frontal impact. It causes transient but catastrophic damage.
Okay, so why does this happen? We need to anchor this concept. Let's call it the bobblehead effect.
That is the perfect visualization. I mean, just think about a child's anatomy. They have this disproportionately heavy head relative to their body. Their cervical muscles are weaker. Their spinal ligaments are far more elastic. And critically, their facet joints, the little locking mechanisms in the spine, are more horizontal, not vertical like in an adult.
So when they get that massive whiplash, that elastic structure allows the vertebrae to just displace substantially.
Right. It can contuse or damage the cord, maybe even temporarily occlude the vertebral artery.
And then, because everything's so stretchy, it just snaps back into place before you can get an x-ray.
It spontaneously resolves. The damage is done, but the picture is clean.
The clinical implication here is just enormous.
It is. If an older child reports any transient symptoms, even for a moment, numbness, tingling, paralysis, you must maintain rigid cervical immobilization.
With blocks and tapes.
Blocks and tapes. A collar only if they can tolerate it. And the gold standard for diagnosis here is not the x-ray, it's an MRI. You have to visualize the cord itself.
Okay, moving swiftly to B for breathing. This is a huge physiological difference.
A critical one. For children, the primary cause of cardiac arrest is typically hypoxia, lack of oxygen.
Which is very different from adults, where it's often a primary cardiac event, right?
Yeah.
An electrical problem or a heart attack.
Exactly. In pediatrics, the heart usually fails because the ventilation failed first.
So the immediate priority, the life-saving move, isn't to start chest compressions. It's to reverse the hypoxia.
You've got it. And the good news, the implication, is that if you can reverse that hypoxia easily and quickly, the cardiac rhythm often just returns spontaneously. You have to win the battle for the airway and ventilation immediately.
Now we hit C, circulation. And this is where we introduce the most dangerous anchor of this entire deep dive.
This is the why.
We're calling this one the silent thief.
This point cannot be overstated. A child is a master compensator. Their physiological reserves are robust. Their ability to peripherally vasoconstrict is aggressive.
So they can maintain a normal blood pressure, looking deceptively stable, for way longer than an adult would.
Much longer. And the devastating reality is that hypotension, a measurable drop in blood pressure, occurs incredibly late.
How late?
By the time that child's blood pressure actually dips, you can assume they have lost at least 20% of their entire circulating blood volume.
Wow. Okay, let's just let that sink in. 20%.
So think about what that means for the trauma team. The moment you measure low blood pressure in a child, you are not about to enter hemorrhagic shock. You are already deep inside it.
It's a critical late warning sign.
It demands immediate aggressive intervention. You have very little time left.
Okay. D for disability,
Yeah.
the neurological assessment.
Right. And you can't use the standard Glasgow Coma Scale, especially for a nonverbal infant. It just doesn't work.
So we use a modified version.
An age-dependent modified GCS. It takes into account nonverbal responses like crying or generalized movements to figure out the child's neurological status. It's an essential tweak for an accurate assessment.
And finally, E for exposure and environment. This one ties everything together, doesn't it? Especially circulation.
It really does. This is the cold threat. Small children have a much larger surface area to volume ratio than adults.
Meaning they just lose heat incredibly fast.
Massively rapidly. And hypothermia is a cofactor in death. It actively and aggressively exacerbates coagulopathy. If you can't keep that child warm, you are actively preventing their blood from clotting.
So wet clothes off immediately.
Instantly. And aggressive active warming, warm to 4 fluids, warming blankets, heating lamps. It's non-negotiable from the second they hit the door.
And a quick practical note. If you're in the trauma bay and the weight is unknown,
Which happens all the time.
right, there's a simple formula to estimate it for your drug calculations.
2 times the age in years plus 4.
Oh.
That gives you a crucial baseline weight in kilograms.
Perfect. So that's the primary survey. Let's move into what happens next.
Active resuscitation. And this is all about fluid and access management.
Stabilization always starts with high flow oxygen, right?
Universally. A non-rebreathe mask. And that mask stays on until you are absolutely certain they have cardiorespiratory stability after a period of observation.
And if you don't achieve that stability,
Then you have to think about intubation. The indications are pretty broad in trauma. Inadequate oxygenation is the obvious one, but also a dangerously low GCS or combative behavior, which might mean poor brain perfusion,
severe burns, prolonged seizures.
or if they need immediate emergency surgery. All indications for a definitive airway.
But getting the IV access, that can be the most frustrating step. A child in shock is clamped down, the veins are tiny.
It's a real challenge. Ideally, you need 2 large, well-secured cannulae.
So where do we look when these standard peripheral veins fail?
We look to the antecubital fossa, of course.
Yeah.
But also the long saphenous vein near the ankle, the femoral vein, the external jugular.
And in neonates?
In neonates, sometimes the scalp veins are the only visible access points you've got.
And when all of that fails, which, let's be honest, is a very common scenario in a crashing child,
The trauma team has to pivot immediately to the IO route, intraosseous access.
this is a critical skill.
This is the skill that separates those who can manage pediatric shock from those who can't. You drive the IO needle into the medullary cavity of the bone.
Most commonly the proximal tibia.
Yes, about 1 to 3 centimeters below the tibial tuberosity, or sometimes the humeral head.
And the main advantage of the IO over just spending 5 more minutes digging for a vein.
Time. It gives you rapid, reliable access to the central circulation. You can push fluids and blood products through it at a high rate. And honestly, this site is often easier for the anesthetist to manage during subsequent procedures than, say, a tricky femoral line.
Okay, let's get into the critical math. Fluid volume resuscitation.
Right, and we have to remember that a child's total blood volume, their TBV, it changes dramatically in the first few months.
An adult's is around 70 millokilorn.
Right, but a neonate is about 85 millokilograms. This actually peaks at around 100 millokilograms at 1 month old before settling into the child range of 75 to 80 millokilograms. You have to know that baseline.
That baseline guides the initial fluid bolus.
Which is 10 millokilograms of a warmed isotonic fluid. Always warmed.
And if the bleeding continues, we're heading towards major hemorrhage. How do we define that?
It's defined by blood loss that's going to need a massive transfusion. So the loss of 50% of their blood volume in less than 3 hours.
Or 100% in 24 hours.
Or, and this is the most acute one, the loss of more than 20% of their TBV in less than an hour. And that ties right back to the silent thief, doesn't it?
It does. So if the child has delayed cap refill more than 2 seconds, and you think it's pure blood loss, you move to the blood transfusion protocol.
Immediately. And the initial blood has to be rhesus negative, the universal donor. You give that until type-specific or cross-matched blood is ready.
This brings us to trauma-induced coagulopathy, or TIC, the inevitable complication.
It is, and managing it is complex. In an ideal world, you'd be using point-of-care testing like TEG or ROTEM to identify exactly which clotting factors are deficient and then replace them.
But if those aren't available?
Then you rely on the standard massive transfusion protocol. You use specific ratios to try and replace what's being lost from whole blood.
Let's nail down that ratio, because this is a high-yield detail for anyone revising.
It's all about a balanced approach you're aiming for. Packed cells at 20 milliliter per kilogram, fresh frozen plasma, or FFP, at 20 milliliters per kilogram.
So 1-to-1 with the cells.
1-to-1. Then platelets at 10 millimoles per kilogram and cryoprecipitate at 5 millimoles per kilogram.
So you're basically trying to recreate a synthetic version of whole blood.
That's exactly it. You're addressing the oxygen carrying capacity with the packed cells and then hitting the clotting cascade with the plasma, platelets, and the fibrinogen from the cryo.
And you're aiming for specific targets.
Right. Hemoglobin over 80, platelets over 75, fibrinogen over 1.5, and normal clotting times.
What about tranexamic acid, TXA?
If that major hemorrhage happened within 3 hours of presentation, there's a clear indication.
And the dose?
A slow bolus of 15 millijoule kilograms, followed by an infusion of 15 millijoule kilograms over 8 hours. It helps stabilize clots by stopping them from being broken down.
This moves us into the heart of the crisis, doesn't it? TIC itself. The problem we call the vicious cycle.
It's simple, but it's lethal. The tissue damage from the injury encourages clotting.
But the consequences of shock acidosis from low perfusion and hypothermia from heat loss actively stop the clotting from working.
Which leads to more bleeding, which leads to more shock, and the cycle just gets deeper and deeper.
Let's zoom in on that hypothermia element again. You called it the cold threat, but let's give it a number. The 10% freeze penalty.
I like that. Every single blood product has to be warmed before it goes in. Because for every 1 degree Celsius drop in core body temperature, factor activity decreases by a full 10%.
10% per degree.
And once that temperature drops below 34 degrees Celsius, clotting times are significantly prolonged, and the platelets, they just pool in the spleen and stop working properly.
There's some complex biochemistry going on here, too.
There is. Poor perfusion, which is happening in shock, increases the release of something called thrombomargulin. This, in turn, activates protein C.
And why is activated protein C so bad in this context?
Because it's a natural anticoagulant. It inhibits clotting cofactors V and 8. So it's basically putting the brakes on the coagulation cascade right when you need it to go.
And it also leads to fibrinolysis.
Right, so it's actively breaking down any clots that have managed to form. It's a double whammy.
We also have the citrate problem from the blood products themselves.
Yes. Citrate is used as a preservative in blood products, and it binds to calcium. If you transfuse really rapidly, the patient's calcium levels can just plummet.
And if calcium falls below 0.6 millimole,
platelet effectiveness drops off a cliff, which is why massive transfusion protocols often include automatic or at least very closely monitored calcium replacement. You're fighting a side effect of the treatment itself.
Let's quickly double back to the neonate, because their whole system is immature at baseline.
It is. Their procoagulant and anticoagulant proteins are naturally low until they're about 6 months old. But the key detail, the one to remember for our final question, is about fibrinogen.
The building block of the clot.
Right. For the first 6 to 12 months after birth, it exists in a qualitatively dysfunctional fetal form. It just doesn't work as well. And that contributes to a baseline increased bleeding risk in the very, very young.
Okay, before we move on, Two quick but important metabolic checks and tubes.
First, hypoglycemia. Children are highly susceptible to it after a major injury.
Why is that?
They just mobilize glycogen poorly. So blood sugar has to be monitored really closely in any kid who's had a major injury, especially if you're keeping them nil by mouth for potential surgery.
And regarding tube placement, NG tube and a urinary catheter are pretty standard, but there are some critical life-saving exceptions.
Yes. If you suspect a basal frontal skull fracture, you must use an orogastric tube, not a nasogastric one.
You don't want to risk pushing it through the fracture into the brain.
You absolutely do not. And second, if you suspect a urethral injury, you'll see blood at the urethral meatus. Often, from a pelvic or straddle injury standard, urethral catheterization is strictly contraindicated.
Because you could make the injury worse.
You can turn a partial tear into a complete transection. Instead, a suprapubic catheter has to be placed, bypassing the urethra entirely until it can be properly assessed.
Okay, that was a really deep dive into that physiological crisis state. We need a quick check-in for you, the listener, to make sure these numbers and anchors are locked in.
Here's your check-in question. We've established that the silent thief means hypotension often signals a blood loss of at least 20%. What two physiological interventions are absolutely crucial for reversing the vicious cycle of coagulopathy? And what highly accessible alternative site should a trauma team immediately pivot to if they struggle to gain peripheral IV access in that crashing patient?
If you can't immediately name the blood loss figure, the two factors, which are temperature and chemistry, and that key access site, please take a moment to rewind. This foundational knowledge is what turns panic into procedure.
Absolutely.
All right, so once we've stabilized the patient's physiology, we move into the secondary survey. We're searching for those hidden injuries. And here again, the pediatric body just changes how we interpret everything.
It does. The injury severity score, the ISS, is a great example. In adults, we say an ISS greater than 15 predicts mortality.
Right.
But in children, you need an ISS greater than 25 to have that same predictive power.
Why is there such a huge difference?
It's really because of the injury patterns. Children often present with these massive, isolated injuries, like a severe head injury or a really complex lung bone fracture, without the simultaneous multi-system organ damage that can quickly push an adult's score past 15.
So it's less common to see the sort of shotgun blast of injuries across multiple body cavities.
Exactly. Only about 10% of children present with those truly devastating multiple system injuries.
And these anatomical distinctions keep cropping up. And a neonate, the fontanelle, the soft spot.
It's a fantastic visual clue. It can be mistaken for a fracture, sure, but more importantly, a bulging fontanelle is a clear sign of raised intracranial pressure.
And a sunken one.
Strongly suggests hypovolemia, dehydration, or blood loss.
The chest is equally deceptive. We mentioned the compliance of the rib cage. It's flexible.
Very. The ribs might just bend and recover instead of breaking, which means you can have severe internal injuries, lung contusions, mediastinal injuries, even damage to the great vessels, without the classic warning sign of a rib fracture on the X-ray.
So that lack of an external sign means your clinical suspicion has to be that much higher.
It has to be. If you suspect a tension pneumothorax, you don't wait for the X-ray to confirm it. You decompress immediately with a needle, then a chest drain.
And cardiac tamponade.
It's rare, but it also requires immediate emergency subxiphoid needle pericardiocentesis. You have to act on suspicion.
When it comes to imaging, there's always this balance, isn't there? The need for detail versus the risk of radiation.
Always. A full head-to-toe CT scan should only be done if there is a really robust, compelling clinical reason. We have to limit that exposure to ionizing radiation.
Still, plain radiographs are standard. A chest X-ray is mandated in major trauma.
It is. And if you're getting a C-spine series, you have to make sure it includes the base of the skull all the way down to the C7T1 junction.
And the odontoid view, the PEG view, can be really hard to get in a kid.
It's notoriously challenging. It requires them to keep their mouth open, which isn't always easy.
The head CT timing has very strict protocols.
Very strict. If the GCS is less than 14 on initial assessment, that CT must be done within 1 hour.
And if it's less than 15 after the injury.
The timeline extends a little bit to 2 hours.
And there are other specific indications for a head CT, Ray, even if the GCS is okay.
Absolutely. A tense fontanelle, any suspicion of a skull fracture open, depressed, or basal, any abnormal pupil response, abnormal posturing, or any focal neurological deficit.
And suspicion of non-accidental injury is an absolute mandate for imaging.
Without question. Even less dramatic symptoms can trigger the scan. 3 or more episodes of vomiting, a witness loss of consciousness for more than 5 minutes, or amnesia lasting more than 5 minutes, all of those get a scan.
What about the abdomen and pelvis?
The CT scan there is similarly indicated by clinical signs: abdominal wall bruising, tenderness, distension, peritonitis.
Or bleeding detected from the rectum or the NG tube.
Right. We also use lab tests as relative indicators. An AST over 200, amylase over 100, or even persistent microhematuria on the urine dipstick can push us toward getting a CT.
And the protocol for that scan is tailored for radiation safety.
It should be a single volume, dual contrast scan to minimize exposure. It's sometimes called the Camp Bastion or Afghan protocol.
Now, a final critical note on imaging the abdomen: the FAST scan.
Yes. The focused abdominal sonography for trauma, it is largely not helpful in children.
Why not? It's a cornerstone in adult trauma.
It is, but a child's body habitus, the small spaces, it makes interpreting the fluid levels just notoriously difficult and unreliable. We rely far more heavily on our clinical judgment and the definitive CT scan.
This leads us directly to recognizing these specific common injury patterns that are pretty much unique to pediatric trauma.
Yes, and they're defined by the collision of small bodies with common objects.
Let's start with the lap belt injury.
This happens when a child, often improperly restrained in a car, experiences this forced flexion over a lap belt. That action violently compresses the small bowel, the mesentery, or the bladder against the unyielding spine.
And here's the key danger, isn't it? The delay.
The delay. The tissues may not fail for up to 72 hours after the initial accident. They might look perfectly fine in the emergency department, only to develop peritonitis days later.
Lumbar fractures are also common with this.
Very common. And in the smallest children, the pancreas can suffer a direct crush injury as well.
Okay, next pattern. The handlebar injury.
The mechanism is a child falling directly onto a bicycle handlebar. It crushes whatever is in its path: the pancreas, the duodenum, the small intestine, or the mesentery against the spine.
The delay danger here is twofold.
It is. Immediately, you're worried about traumatic pancreatitis or a divided pancreatic duct. But the more insidious dangers are a duodenal hematoma causing an obstruction days later.
Or a contused bit of intestine that perforates after a delay of a few days.
Exactly. This pattern absolutely mandates a prolonged period of observation. You can't just send them home.
And finally, the straddle injury.
A fall onto the side of a bath, a fence, a toy, causing blunt trauma to the perineum. And this injury, especially in girls, can involve the urethra or the vagina.
Now, we have to address the difficult reality of non-accidental injury, NAI.
The suspicion must always be there when the reported mechanism or the timing of the injury just seems inconsistent or unusual.
There are clear red flags.
Very clear. Fractures, abdominal injuries, and intracranial hemorrhages in any child under 2 years old are highly suspicious for NAI.
And what about bruising?
Bruise assessment requires very detailed attention. They're hard to date, sure, but the pattern is key. Pattern bruises that suggest an implement, or bruises over soft tissues in an infant who isn't mobile yet.
Right, or bruising on those high suspicion sites.
Cheeks, neck, genitals, buttocks, and back, those are all red flags. Accidental bruises typically happen over bony prominences in kids who are up and running around.
It's also crucial to remember the differential diagnosis.
Absolutely. You have to rule out benign things like Mongolian spots or hemangiomas, and systemic conditions like leukemia or ITP, which can all mimic the appearance of abuse.
Okay, let's try and apply this to a fictional case study to really ground that concept of delayed injury.
Let's do it. We have a 6-year-old who comes into the trauma bay after a bicycle accident. They fell directly onto their handlebars. They're initially stable, but they have distinct abdominal wall bruising and tenderness right over the middle of their abdomen.
So based on that specific handlebar mechanism, what internal injuries does the trauma team need to be hyper alert for, both right now and days later?
Okay, immediately you're worried about a crushing injury to the pancreas or the duodenum, something that could cause severe internal bleeding or traumatic pancreatitis.
But the really dangerous part is the delayed failure.
That's it. We have to watch for a duodenal hematoma causing an obstruction, which might evolve slowly over a day or two. And critically, we have to worry about delayed perforation of a contused loop of small intestine, which might only fail 48 to 72 hours later.
The implication is clear then. Even if that child stabilizes and their first CT scan is clean, the handlebar injury pattern mandates a period of observation.
And potentially serial examinations. You simply cannot discharge them based on a single stable assessment.
So once we have the diagnosis, we shift to definitive management. And the philosophy for the abdomen has, well, it's undergone a massive change over the last few decades.
It really has. For abdominal trauma, the immediate life threats still dictate what you do. Intraperitoneal air-free air in the belly means immediate surgery, either a laparoscopy or a laparotomy.
For everything else.
The vast majority of non-penetrating blunt injuries are managed non-surgically.
The 70% rule guides our focus here.
Right, the liver and the spleen, they account for 70% of all blunt visceral injuries in children.
And here is the core management philosophy, the big takeaway.
In a hemodynamically stable child, most solid organ injuries to the spleen, the liver, the kidneys are managed entirely non-operatively. We let the body heal itself.
So when do you operate?
The indications are very clear-cut. Instability, despite appropriate, aggressive transfusion, a transient response to resuscitation, so they get better, and then they crash again. Or failure of interventional radiology, like embolization.
But let me challenge that for a moment. If a child gets a massive transfusion and then a few hours later needs another one, doesn't that automatically mean they need to go to the operating room?
Not necessarily, and that is a crucial caveat in pediatric trauma. Recurrent instability might simply mean the initial resuscitation was inadequate. Maybe we didn't catch up to the blood loss fast enough, or we let them get too cold or too acidic.
So the need for a second transfusion on its own
Does not mandate an operation, provided the child is stable and responding appropriately now.
What does post-injury mobilization look like for these non-operative cases?
They need bed rest until they're completely pain-free. The guidelines suggest a minimum of 1 night of rest for grade 1 and 2 injuries and at least 2 nights for grade 3 or higher.
And for the most severe ones?
For grade 4 and V injuries, high-impact activities and contact sports have to be restricted for 6 weeks.
And we have to counsel the family about delayed hemorrhage.
It's incredibly insidious. It can happen spontaneously several days later. The thinking is that it's related to the breakdown of the initial hematoma, the clot around the injury site, which causes fresh bleeding.
So discharged patients need to know exactly when to come back.
They need very clear red flag warnings.
Let's delve into some specific organs just to appreciate the complexity of what we're allowing to heal. Let's start with the spleen.
The injury scale really illustrates the complexity. A grade 3 spleen injury could be a subcapsular hematoma covering over 50% of the surface area, or a laceration 1 to 3 centimeters deep. And despite that magnitude of damage, we let it heal.
And the spleen carries a unique risk that's not even related to the injury grade.
Exactly. Splenic pseudoaneurysm. This requires diligent follow-up. An ultrasound is standard practice to make sure one hasn't formed, because that would be a ticking time bomb needing intervention.
For the liver, it's about sheer volume. The body's ability to heal a massive liver injury is astounding.
A grade V liver injury involves parenchymal disruption of over 75% of a hepatic lobe. That is a massive injury.
And when we talk about lobes and segments, we're referencing the work of Claude Cuneau.
We are. He mapped out the liver's 8 functional segments, which is how surgeons talk about the extent of the damage.
And what about bile leaks?
They're rare, and usually they resolve with just a simple drain rather than needing a big surgical repair. But any significant leak requires a discussion with a pediatric liver surgeon.
The pancreas is notorious for its delayed complications. What happens after a crush injury?
It can lead to a pancreatic pseudocyst, which is a collection of fluid and enzymes that might need to be drained endoscopically into the stomach.
And management options vary.
They do. For distal lacerations in the tail, some surgeons still prefer an early distal pancreatectomy over trying non-operative management, just given the risks of a chronic fistula or recurrent pseudocyst.
What about proximal duct injuries?
In older children, if possible, those can sometimes be stented endoscopically to allow them to heal.
Renal injuries present a specific late threat.
Hypertension. Post-severe renal injury, hypertension can develop, and it requires treatment. We use a DMSA scan to assess the remaining function after a grade 3 or V injury, or if hypertension develops, to see how much kidney function is left.
Okay, circling back to the duodenum, we already said delayed perforation is a major concern.
It is, and the danger is compounded because the duodenum is often retroperitoneal. It's behind the main abdominal lining. So a perforation might not cause classic peritonitis right away.
So if recovery is slow,
or the child deteriorates, you need a second CT scan or a contrast study to definitively rule out that delayed hidden perforation.
and small bowel injuries have 3 ways they can fail us.
Right, a rapid pressure rise in a trap loop causing an immediate rupture, a direct crush injury from a seatbelt or handlebar, which can be delayed up to 72 hours, or ischemia from a mesenteric injury cutting off the blood supply. You have to be suspicious of all three.
And again, tying back to our initial survey tubes, urethral injury. Blood at the meatus means a standard catheter is out.
Absolutely contraindicated. You can make it worse. A suprapubic catheter has to be placed to drain the bladder until the injury can be formally repaired.
So when non-operative management fails, or if the child is just too unstable to survive a long, complex repair, we shift the entire priority system.
Damage control surgery, DCS.
And this is all about breaking the vicious cycle.
Entirely. If the child is hypothermic, acidotic, and coagulopathic, a long, definitive anatomical repair will kill them. The principle is, fix the bleeding and contamination now, resuscitate the physiology later.
It's a three-phase approach. Phase 1.
The short operation. Control hemorrhage, limit contamination. It should last less than an hour. The goal is survival, not perfection.
Phase 2.
The ICU, ongoing aggressive correction of that deranged physiology. Warming, fixing acidosis, restoring perfusion, managing the coagulopathy. This can last for days.
And Phase 3.
Definitive repair. The surgeon goes back to the operating room in the following days, once the patient is physiologically optimized, to do the final anatomical repair that they just couldn't tolerate on arrival.
Let's detail the trauma laparotomy technique for DCS.
It starts with a long midline incision. First step is to get the large clots out and then pack the abdomen. Swabs go in all 4 quadrants to tamponade the bleeding.
And if that packing fails?
Then the thought process is simple. Either the packing is inadequate or this is a major arterial bleed, probably from the aorta or a major branch. In that case, you apply immediate pressure to the aorta, usually just above the liver.
Once stable, how do you find the source?
You systematically remove the packs 1 quadrant at a time to find the source, and the control methods are rapid. A quick vessel repair, a ligation, an organ removal like a splenectomy, or you just reapply the packs if the patient becomes unstable again.
Contamination control is similarly fast.
Very fast. You don't take time for complex repairs. A simple bowel injury gets a quick continuous suture. Multiple perforations get a clip and drop. You just staple or tie off the ends of the bowel.
No primary anastomosis.
Critically, no. It takes too long and it will fail in an unstable patient. Bile injuries are drained. Bladder injuries are oversewn.
And the final, signature step of DCS.
The abdomen is left open, often covered with a temporary dressing or a vacuum system. This allows for immediate transfer to critical care for that crucial physiological correction before you go back days later for the formal closure.
And finally, we reach the most extreme last-ditch measure, the emergency clamshell thoracotomy.
This has a very specific, very narrow indication. It is reserved only for a penetrating chest injury where the patient had a witnessed cardiac arrest within the last 15 minutes. It is a Hail Mary path.
The procedure itself. It's an incision across the 5th intercostal space.
Right across the chest. The sternum is split, often just with heavy scissors. You don't always need a giggly saw instantly. The pericardium is opened and the blood is evacuated.
The goal isn't a definitive repair.
No. The goal is immediate hemorrhage control and buying time. You're aiming for internal cardiac massage until you get some output back.
And the key maneuvers.
You can try to carefully oversew a hole in the heart, avoiding the coronary vessels. For severe lung bleeding, sometimes you can rotate the lung 180 degrees, the lung twist, or loop the hilum.
And the thoracotomy gives you one final advantage.
It allows the surgeon to get their hand in and compress the aorta just above the diaphragm, and that helps direct whatever blood flow you have towards the heart and the head, buying crucial minutes for resuscitation.
We have covered so much critical ground in pediatric trauma management, from the bobblehead effect to the brutal efficiency of damage control surgery.
We have.
So let's run through your Ready Reckoner review, the key distinctions from this chapter.
Okay. First, pediatric trauma uses ATLS, but the context is everything. Remember, overextension of the neck compromises the airway.
And remember Sekiwara. Cervical injury can exist without any signs on an X-ray.
Intraosseous access is a key skill for small, unstable children. And never forget the life or death difference of the silent thief. Hypotension means at least 20% blood loss has already occurred.
Lung contusion can happen without rib fractures because that chest wall is so compliant. And in a stable child, the CT scan is the superior tool for assessing the abdomen. But you have to use radiation-conscious protocols.
Blunt abdominal solid organ injury is overwhelmingly managed non-operatively in stable patients.
And damage control surgery's #1 priority is always correcting the physiology, breaking that vicious cycle of hypothermia, acidosis, and coagulopathy before you ever attempt a definitive anatomical repair.
Mastering these distinctions, it really enhances your ability to perform in these incredibly high-pressure environments. So please, use this deep dive as your framework as you structure your own comprehensive review of the chapter.
We've discussed how severe injury accelerates all these dangerous metabolic derangements in children, especially hypoglycemia, and we highlighted that neonatal hemostasis is fundamentally immature.
So here is a final provocative thought for you to take away. We noted that fibrinogen, that core clotting protein, exists in a qualitatively dysfunctional fetal form for the first 6 to 12 months of life.
Right.
Given that baseline deficiency in the actual structure of the clot, how might this immature fibrinogen shift the clinical decision-making threshold for a surgeon who is debating non-operative versus operative management in an otherwise stable but very, very young trauma patient, even before significant blood loss has even occurred?
It's a challenge of balancing the body's incredible healing capacity against the inherent physiological risks of a newborn. A fascinating thought. Thank you for joining us on this essential deep dive into trauma in children.
Our pleasure.
We'll see you next time.